So now today we have Apurva Zawar, and she actually reached out to us, which I was so excited because she wanted to talk about pain and Parkinson's. And I'm going to introduce her in a minute, but I just want to share. I was just so excited when we started talking because it was so clear that, I feel like sometimes pain can be kind of dismissed in Parkinson's. And not only did she just completely get it, she works with it, she treats it. And so it was just such a great conversation. So I'm so excited that she wanted to come and talk to us today. Apurva Zawar is a passionate neurological physical therapist, educator, and mentor, and I can vouch for that. She owns and practices at BeyondRehab, a digital neuro rehab and wellness clinic covering California, Massachusetts, and Washington. Additionally, she's a board-certified geriatric clinical specialist with expertise in managing movement disorders and persistent pain care. She received her master's from MGH, IHP, and Doctor of Physical Therapy from Neuro Recovery Training Institute. She has worked across various rehab settings in the US with highly expert multidisciplinary teams in treating neurological conditions. Her primary focus of work involves serving and managing complex care conditions such as Parkinson's disease, functional movement disorder, and chronic pain through an integrative care approach. She strives to provide an intense, total body approach to fitness, rehabilitation, and wellness. Thank you. Thank you for joining us today, Apurva.
Thank you, Eden, for the introduction. Welcome, everyone. It's a pleasure to connect with you guys and share this topic of managing pain and PD. So today I'll be talking about how managing pain and PD using non-pharmacological approaches. So the objectives for today's sessions are primarily understanding the prevalence of pain in Parkinson's disease, its presentation across the stages of Parkinson's, differentiating PD-specific pain from non-PD specific pain, identifying the different types of pain experienced in PD, and lastly, we'll be learning about how exercise can be a powerful tool to cope with the pain and different self-care pain management programs to help you better manage the pain in Parkinson's disease. So what does pain mean to you, right? Pain is a very broad topic. Every time pain experience differs from person to person, from like different time of the day. So many factors are involved in the pain in better understanding the pain experience. So one of the recent definition from Society of Pain was an unpleasant sensory and emotional experience. It's associated with actual or potential tissue damage. And as you know, like pain is multidimensional and it's biopsychosocial in component, meaning it depends upon depends upon your underlying condition, your tissue health, comorbidities. Psycho factors depend upon your mental and overall emotional wellness. Social factors depends mainly just your interpersonal, social connection, community factors, lifestyle factors. So together, all these components help aids into the overall pain experience. And it just differs from person to person, from time to time. So it's always not not directly proportional to the tissue damage. There are multiple other factors involved in the overall experience of pain. As we are starting to understand and learn from each other about pain, I'd like you to answer this question. How often do you experience the episode of pain? Is it rarely, once a week, occasionally, frequently? So we see it's still going. So we see majority of individuals, the group experience the pain throughout the week, so more frequently. And then we have a small cluster of individuals experiencing pain once a week or a couple times a week. So that's good to learn. So how, when it comes to pain in Parkinson's, how common is it? It's almost 40 to 80% of individuals experience the pain, and it depends upon the type of the pain that changes. One of the most common premotor signs, which is seen almost 1 to 2 years earlier to the diagnosis of Parkinson's disease, is frozen shoulder. So you might hear from individuals that they started manifesting or presenting with frozen shoulder, and eventually they were referred to the neurologist and then received the diagnosis of Parkinson's disease. So pain is one of the earlier non-motor symptoms which individual experience in the early stages of the PD, and the late stages, pain is more pronounced as compared to the early stage, but there's a wide difference between the presentation of pain in the early disease versus the late stages. But in general, pain is common across the course of disease. So why is pain common presentation? So the pain is common mainly because there's a dysfunction in the pain pathways. The pain processing is different in context to the Parkinson's disease that leads to the changes in the pain perception. There's dysfunction of the dopamine circuits, and also a higher incidence of musculoskeletal problems in the PD, mainly because of the motor symptoms like slowness of movement, rigidity, changes in posture, gait, which contributes to the musculoskeletal problems, and which in turn have an impact on overall pain processing and postural and musculoskeletal alignment. And also it's under recognized and under treated. The other is the pain is differently felt in Parkinson's disease because of there is the reduced threshold of pain in Parkinson's disease, and also there is altered pain sensation, which results to the difference in the pain perception in Parkinson's disease. So there are multiple causes of pain in PD. So as pain is complex and there are it's multifactorial, and it can occur anytime during the disease. Pain in Parkinson's can be related to musculoskeletal changes, and at times it's amplified by the motor and non-motor PD symptoms. So this is one of the primary cause of the pain in Parkinson's disease. So this was an overview of how the pain is prevalent in Parkinson's disease and how it changes over the course of disease. Now I'll like to dive into further and understand ways to differentiate the PD related pain from not from PD unrelated pain. It's important to understand, is this pain associated with the Parkinson's disease, or it's non-PD specific pain? So I'd like you to solve this screening test together with me. So this way we can differentiate the PD pain from non-PD specific pain. So the first question is, any pain feature you experience, is it related with the PD onset or the disease course? Did you experience the pain with the start of the Parkinson's disease, or during the course of it, or it was there like prior to even the diagnosis of Parkinson's disease? Put yes or no. The second question to look into is the pain related with the motor fluctuation? Do you feel difference in pain during the on stage versus the off stage? Or does it change with the dopaminergic treatments? Put that yes or no. The second, how's the overall impact to the anti-Parkinsonism treatment? Do you see the treatment, the dosage helps you to alleviate or resolve any pain feature? If you answer yes to all of these questions, it guides you more towards the PD related pain. If not, then it's more non-PD related pain. I have a nice diagram here, so you can again like look into the each components. Is pain related to the onset or the course of the disease? Does it change with motor fluctuation, mainly during the on and off phase? Do you see an impact of the Parkinson's anti-Parkinsonian treatment on your pain? If it's yes to all of these questions, it guides you towards PD related pain. Um, if it's no, it's more towards non-PD related pain. Um, let's look into the second poll questions. How will you classify your pain? Pain related to PD or pain not related to PD? So a majority of you reported the pain is related to PD, 66%, and pain not related to PD is 34%. Great, thank you. Next. So now the key topic for today is understanding what are the different types of pain. So, pain is really broad, as we all know. It can be further classified into 5 different categories. So the first is musculoskeletal pain, more associated with the joint and muscle and postural changes. Dystonia associated pain, it's the pain experienced during the off phase or in the night time. Radicular or peripheral pain, more across the nerve root, the nerve region. The last is primary central pain and apathetic discomfort. I'll be talking about each one of it. So musculoskeletal pain is one of the most common PD related pain, and it's seen in almost 45 to 90% of individuals. The pain features include aching, cramping, arthralgic, myalgic sensations in the joints and muscles. It may include muscle tenderness, arthritic changes, skeletal deformity, limited joint mobility, postural changes, gait changes. At times, it is exacerbated because of the rigidity, stiffness, and immobility, and it improves with mobility. It may fluctuate with a dose of medication and improves with levodopa. So one of the common presentation of musculoskeletal pain is the low back pain and frozen shoulder. And it appears very, the pain presentation gets relieved at times with simple stretching, simple movement, and it can be easily resolved as compared to the other pain and easily diagnosed. And it's very local. Like if you feel the pain, it will be mainly focused around the shoulder region, any movement exacerbated. And if you're keeping it still, it might relieve it. That's the typical presentation. And the common symptoms which you feel will be more of achiness, joint and muscle related pain or tenderness. The second is the dystonia pain. It's not often talked about, but the pain presentation ranges from 15 to 50%, and it's an uncontrolled muscle contraction accompanied by deformed posture, usually seen in the hands and feet. Uh, there are various clinical features, presentation of the foot dystonia, ranging from inward movement, raising of the toe, big toe, or the combination of movement. It's typically seen in the morning before the first dose of levodopa, and it gets better with medication. Uh, the big challenge is because of the foot and the toe changes, it's difficult to walk or it's difficult to do any weight bearing task. So if you see yourself like your pain gets better right after the medication, and if you see any of these changes, it's more guiding towards dystonia associated pain. The The third one is radicular or peripheral neuropathic pain. It's seen in either arms or legs, and it's present amongst around 20 to 30% of individuals. The primary symptoms include burning sensation, electric shock sensation, pins and needles, and it across the nerve root. So it may be more like sciatic nerve, tingling in arms and arms across different regions in the front and the back. So that's the typical presentation. And it is exacerbated because of the changes in the posture. If you see sitting in the wrong posture, or any fluctuation in the posture might trigger the symptoms. And similarly, if you follow any of the nerve stretching, muscle stretching, it might alleviate those symptoms. The other one is central or the primary pain. It affects almost 10% of people with PD. It is described as more stabbing, burn sensation, and it's diffused across the body. At times, it's hard to explain the presentation because it's more generalized. There are no alleviating or relieving factors in central pain. It just differs from day to day. So those are the primary presentation. And one of the leading hypotheses for this type of dysfunction is mainly because of the changes in the pain pathways or processing of the pain inputs within the nervous system. The last one is akathisia. It refers to as unpleasant agitation sensation, commonly described as restlessness syndrome, and it occurs in 20% of Parkinson's patients. Additional to all of the above pain, there's also chronic pain in the GI region, which can include symptoms like dysphagia, constipation, impaired gastric emptying. So these are like the common pain presentation which are primarily seen in individuals with PD. So I'd like to know and learn from you, how will you categorize your pain presentation? So I see musculoskeletal pain as one of the most commonly experienced pains. So almost 56% experience it, and dystonia is on the second. So those are the two primary presentation individuals have in general, and I see the same in the group. Okay, thank you. So as you're learning and understanding about the pain, what are different types of pain, it's equally important to self-assess and track the pain symptoms. One of the ways to do it is maintaining a pain diary, and that will help you better understand how is pain presenting, and also effectively communicate with your healthcare team. So one simple way to do is use the mnemonics old card. It will help you put down like the onset of the pain, the location of pain, duration, how long has it been present, what's the characteristics, severity, and quality. Like, do you feel more like burning, more like aching? What are the aggravating factors? What are the relieving factors? What treatment interventions you're receiving for the pain presently and in the past? So this all information will be really important for you to present it to your healthcare team, and they'll be help you better diagnose it, better plan the treatment, and explore the treatment options. So definitely keep this in mind. Maintaining a pain diary, simple or like more detailed, will be a good start. So as as we are like diving into the pain management treatment option, I'd like to learn if you're receiving any of these treatments like medication, interventional procedures, physical therapy, psychological therapy, complementary medicine, or surgery for your pain management. So medication is on the top right now. So definitely medication followed by physical therapy is the primary commonly used to manage the pain. I'll be talking more about use of exercise and other treatment rehabilitation strategies to manage pain today. Thank you. Results. So as we are learning today primarily about the non-pharmacological approaches for managing pain, so how does exercise helps in pain management? So exercise is an important non-pharmacological approach. It helps with neuroplasticity, meaning it helps with the brain's ability to reorganize by itself, um, by forming the neural connection, and help with coping of the pain. So uh, with the exercise primarily promotes neuroplasticity and neurorestoration, uh, and also it helps you modulate the dopaminergic and non-dopaminergic pathways in pain modulation. So that's like the overall the big picture of how exercise helps in pain management. So the good news is, like, the scientific studies over many years have proven that pain management can help you better cope with pain by helping you move differently, become more fit, flexible, breathe, think differently. It's all about retraining, relearning, and learning about how to actively engage, cope, and better resolve the pain symptoms. It's all through through exercise, through the power of neuroplasticity. So it's a common theme, right? Exercise does help in pain management, but where do we start? What do we do? What's the first step? So the first step, it's important to get a baseline assessment of your physical activity level, your functional demands, and what are your goals which you're not able to achieve because of your underlying pain conditions in Parkinson's. Following that, it's important to understand the pain neuroscience. How does pain work? You know, how is the pain experience formed? Like, is it just it's not just one factor which leads to pain, right? There are multiple factors which leads to the overall experience of pain. So pain is more of an emergent process. So understanding what are the components contributing to overall experience of pain, learning how the nature of pain is different in PD. So as we were talking about before, like pain processing in PD changes because there is a reduced threshold of pain perception in PD, and also the pain processing signal, the sensitivity changes in with Parkinson's disease. So understanding the influence of pain in PD, so that will be a good foundation, followed by how do you gradually increase the physical activity, work on retraining the sensory and motor training. So that will be the next step, followed by on developing a flare up episode plan. there'll be days like you'll be doing really, really good, everything's going good, and there'll be certain days, sudden spike in the pain. So how do you cope with those flare-up episode? Or what all do you have in your toolbox to effectively manage it will be very important to plan and practice with time. So those are the starting points. So along with it, pain management needs a multidisciplinary approach. It needs to integrate the care from the pharmacological aspects and other method of pain management. So it needs to be an integrative care. So if you are receiving treatment, more of a pharmacological treatment and physical therapy treatment together, make sure you let your providers connect or share information with each other so they can effectively have a better picture of what all treatments you're receiving and how it's helping you, and how you're coping with time. Similarly, it's important to have a healthy foundation, meaning working on optimizing your sleep, eating well, gradually increasing the fitness level over time. That will be a good way to move forwards. So it's it's simple, but just look into more into the systematic way as you're using exercise to integrating exercise in your treatment plan. So doing it gradually, doing it in the supervision of your team, and communicating with all the providers as and when possible will be effective. So I like to learn, how much does your pain impact your ability to exercise? Is it a minimal impact, minor impact? So I see like there's a mix, there's like a break between minor, moderate, and significant impact, like all like around 30% each. So definitely, and it changes, right, from time to time, from day to day and week to week. So um, pain does limit the ability to exercise. So that's the other part. But on the contrary side, exercise helps you in pain management. So keeping that in mind, it's important to gradually have like a baseline assessment, like what, on a regular day without exacerbating your symptoms, what all can you do, and keeping that in mind and gradually step by step improving the level will help. And also working closely with the team or with PT, whoever you have in your care team, will help you further improve your help you return back to the exercise or improve your activity level. So few of the key principles while looking into integrating exercises for pain and PD. So when it comes to musculoskeletal pain, it's important to target the underlying muscle strength, mobility, and functional impairment. So if you see like you have a frozen shoulder and it's more of the joint mobility issue, or if it's more of the muscle issue, so having that assessed, getting a good assessment, and creating a plan on how to relieve those signs, those tightness, strength deficits, and functional impairments, creating a plan, gradually integrating it in your daily routine, along with improving overall fitness, overall function, will be the way to address the pain. So the first step is looking into whatever the deficits you experience, communicating it to the provider, and making a plan and integrating it in your daily routine is really, really important. Followed by peripheral neuropathic pain. So addressing the compression of the nerve root or neural sensitivity with simple neural dynamic stretching, nerve tissue tension stretch, postural alignment, strengthening, and similarly gradually integrating it and improving the fitness level step by step. When it comes to central neuropathic pain, it's important to get the right diagnosis followed by graded activity level. It needs to be well supervised and gradually gradually improved, increased the intensity level with time, along with the proper monitoring of symptoms over the course of the treatment plan. So these are the key features of how the treatment plan of integrating exercises will look like. So as you're planning to integrate the exercise routine using more of a non-pharmacological approaches for managing pain, it's also important to look into the multimodal pain management. So having like integrative care approach. So if having a good network between the rehab team, medical doctor, if you're working with any of the lifestyle or alternative medicine specialist, also communicating with your providers and letting them know how is your overall response, what's helping. So that will help the team to better plan the treatment for you and also track the progress over time. So that's the overall theme of how exercise can be gradually looked into as a ways to manage exercise. Also, one of the common programs which is getting popular for self-management pain in PD is it's like an integrative program, and it helps you become an expert on managing your pain. It helps you better address the concerns about pain provoked by activity, helps you get more fit, and create a toolbox of skills and techniques and exercise that will help you stay active and return to previous activities. So it's one of the ways to actively learn, actively engage, and work on efficiently managing pain in PD while you're also working with your team or other providers as needed. So at BeyondRehab, one of the programs which I offer and work with is PD Power Up Pain Management Program. It's a 4 weeks immersive program, and it's done virtually in a small group of 4 to 6. And during the time, the 4 weeks, we learn about ways to empower the pain understanding, working on reconnecting, retraining, creating a toolbox to better address the flare-up episodes and freezing episode, and creating a plan to re-engage and master the skill sets with time. So it's done in a group setting, so that makes it more unique. Individuals learn from each other, lots of sharing of information, and also practicing. Practice is the key, and it's also about overcoming the fears, overcoming and addressing the underlying changes and concerns will help you better manage the pain. So outcomes of any of the pain programs is primarily to help you better understand the pain, learn active scoping skills. This is really, really the key, like shift of health and well-being responsibility from the healthcare professional and therapist to the person. So you are the active driver. You are engaged in actively coping, understanding, and managing your pain. That's the end goal. So with time, with the resources available, with practice, you'll be able to get there. So highly focus, if like getting more involved, getting more engaged, and relearning, practicing with time, that will help you better manage your pain. And also focusing on re-engaging in life activities by gradually overcoming the fear and increasing movement and engagement. So these are the references. So that's all from my end, but I'm open to the questions and answers now. And it's if you have any questions, or if you'd like me to repeat any of those topics, refer back, I'll be happy to do that.
We have put some of the information in the chat if people want to save their chat. If you click on the 3 buttons, the 3 little dots next to the smiley face, you can save your chat that way, which we encourage because we put some good information, including accessing this tomorrow, as well as the information that Dr. Zawar has put up. So I do have a few questions. The first being, because a few people commented on the poll questions, is it common that people have multiple pains? Because they were kind of saying that I want to choose more than one. And
Yeah, it's common to have a multiple different types of pain together. Around 20 to 30% of individuals do experience combination of pain. And it's more common in the later stage of Parkinson's disease.
And someone asked if you could please talk a little bit more about dystonia pain and big toe movement.
Um, so dystonia pain is mainly experienced during the off stage of the cycle. So if you see your pain during the off phase, and if you experience a repetitive movement, or if you experience a sudden change in the foot posture, that's when it's more associated with dystonia. One of the common ways to alleviate the dystonia pain is medication. So if you see right after the medication, your symptom improves, that is more related to dystonia. It's one of the important points which you like to mention it to your neurologist, and let them know about your pain during the off phase. So at times they'll be able to modulate the pain the dopaminergic medication, anti-Parkinsonian medication, and that will help you relieve the symptoms, and that will be one good first good step to begin with. And the second, when it comes to rehabilitation, there are ways to retrain, reconnect and relearn the movements. So different strategies like sensory training, postural training, motor training helps in better managing the dystonia pain. So those are the combination. So depending upon the presentation, depending upon how long standing it is, different options can be implemented.
Talked a little bit about off time. Somebody asked, what happens? How can exercise help severe off muscular skeletal pain? And this person said she noted that this is somebody who exercises intensively every day when well medicated and on, but what can she do for the pain when she's off as far as exercising?
So during the off phase, so it's important to consider low intensity exercises. So if you experience pain during the off phase and it's more musculoskeletal related pain, so looking into options like stretching, simple stretching, see if that alleviates the pain, the joint pain, the muscle pain, followed by working on the posture. If you see, like if you have a bad posture, if working on postural retraining, not very demanding, and see how that alleviates, that will be a good way. And also gentle exercises like functional training exercises, just doing body movements, change in body movements will also help. Depending upon the body parts and the region, you'll be able to look into it. But while you're looking of using exercises during the off phase, think of it more as like low intensity, more of stretching or muscle relieving techniques to be used to relieve the pain.
Someone also asked about, like, what about headaches? What can be done exercise for headaches?
Headache is a very broad topic, so it will be difficult for me to answer it. But definitely, if you see the onset of headache along with during the start of the Parkinson disease, so that's something you like to communicate and talk more with your movement disorder specialist and see, screen it out, like is it more related to Parkinson's or not, and then gradually then go from there. So talking to the neurologist and screening out the other associated headaches will be the first point to begin with.
And then somebody asked, and you kind of touched on, because I guess when you talked about the restless leg a little bit, what can we do about the way pain interferes with sleep?
It's tricky. I know it's at times positioning helps. So if you see like using a pillow, changing positions, changing the leg position, that might alleviate the pain. Or depending upon the weather, at times people have found it useful to use the weighted blanket. to relieve the pain. So there's like a broad range of options, and depending on the type of pain and the like the frequency, how often you experience it, that those factors will help you look into the treatment options. But I guess the positioning and looking into and exploring different position will be a good start.
And then someone asked, other than, is there anything else we need to know about how do you join your program? Is there anything else? Because we did post a few things. We put the information about BeyondRehab. We put the phone number, the info at, and is there anything else we should be adding?
No, if you think is this something you're really interested, I'd like you to like connect with me. So the first step is just connecting and learning what the program is. I'll be screening you and seeing if this program is the right fit, and accordingly, if it's a right fit for you, and then we can go to the next steps of enrolling and assessing further.
And then you talked about the frozen shoulder being something. Is that the shoulder problem? Someone asked, is that usually or always associated with Parkinson's, or is that just kind of something you have noticed?
It's more, I've noticed in my clinical practice, and also research has also proven it. Like it's one of the common premotor symptoms of frozen shoulder, and it's not easy like directly associated with Parkinson's, but then over time, based upon the relievement, like alleviating factors not falling in place, then gradually they are like guided towards the Parkinson's diagnosis. But it's been noticed that frozen shoulder is one of the premotor sign, but still not like very clear. But that's the few based on the evidence we have.
How can someone manage comorbid pain, such as spinal and joint orthopedic issues with the Parkinson's pain?
So spinal pain, the best way to start is looking into the postural retraining. So focusing on your postural alignment in different position, at the same time working on the muscle strength and mobility. So looking into like strengthening programs for your low back pain, for your core muscles, mobility, flexibility program. Integrating it in your daily program will be a good way to manage it. And also gradually increasing and advancing the intensity level with time. As you see, like this is really relatively easy, then probably looking into way to advance the intensity and the exercises will be helpful.
One thing you and I talked about is that a lot of times people are kind of dismissed when they're told, I have pain and Parkinson's. If you feel like someone's being, what advice might you give to a patient to say, hey, I respect that you're the doctor, but I am having this pain, and I actually just went to this seminar, for example. Like, what would you say?
So one of the key things is keeping a pain diary. Like, it's really, really important. If you have like a simple way to track your pain, like if you feel it, just put down like, when do you feel it? What's the aggravating factor? What's the relieving factors? What treatments are you getting? And track it over time. So whenever you go to the doctor, you can present that information. Like, you experience more of a burning pain throughout the week, throughout the month, and, nothing is helping, or maybe certain stretches help, but it again comes back. It's nothing is relieving it for a long time. That information will really, really prompt the provider to easily further, diagnose it and also create a treatment plan for you. So with the help of pain questionnaire or pain diary, you'll be able to do it easily. Just remind yourself to keep a track of it.
Question from a young onset. Are you aware of any links between complex regional pain syndrome or reflex neurovascular dystrophy, especially among adolescents, with young onset Parkinson's disease?
I just happened to read one article, and they were talking about this association of regional pain syndrome in young onset Parkinson's disease, but it's not much information or research is still available. So something which I'll be it like, yeah, it's not yet out there, but it depends. The prevalence is gradually being seen more, but no direct correlation has been associated.
Someone asked, is the physiological treatment for Parkinson's disease related musculoskeletal issues different from non-PD ones if they're affecting the same set of muscles? Which, as you were talking, my aunt actually has a lot of pain, and I thought, oh, I wonder if she could benefit from this. But then I thought, well, you're looking specifically at Parkinson's disease. Would there be a difference, or?
Uh, the big difference is like when it comes to Parkinson's disease pain. So it definitely the pain perception changes and it fluctuates during the on and off phase. So that guides more towards like robust or different treatment strategies versus non-PD specific pain. It's overall the presentation doesn't vary to that extent, and but the treatment principles, the guiding principles are relatively similar when it comes to non-PD specific pain. It's just the context and the background is different, so the factors influencing it changes, so similarly the strategies will differ a bit.
How can you tell me how what you do complements if people are currently exercising, doing some rock steady boxing and things like, can you explain how you're complementing what they're already doing?
So definitely exercise is one of the powerful ways to improve the neuroplasticity and helps you cope and better process your pain. So with the help of exercise, you'll be creating a good foundation. You'll be creating a good neural network, which will help you effectively improve your pain processing. The only thing, while you're actively engaging in any of these regular exercise regimen, also keep in mind you are followed by the exercise, you have a plan to relieve it, you have a plan to cool down, and then gradually get back to your daily routine. So that will prevent any of the trigger episodes, and that will help you to keep up with your regular routine. So creating a plan of how to warm, putting extra minutes, extra time prior to the start of the program, exercise program, and also to cool down, then it won't be of more of a muscle tension, irritation, or any of those changes which might evoke pain experience. So um, and also one thing, simple thing which you can start doing is creating a toolbox. If you think like there are certain tools which really help you relieve your pain, more like muscle pain, keep that handy. As soon as you're out from your exercise class, grab it, relieve it, and then get going with your routine. So those strategies will help you balance it and manage it more effectively. And lastly, think about pacing. So if in the morning, if you're going for the exercise class, you want to make sure you're not following up with other more like physically demanding task, like going to the grocery, or you're pacing it out in simple words. So divide your day in a way. So if it's morning is exercise, give yourself enough time to cool down or do some more of a light routine, and then get back to other tasks. So pacing will be other important consideration while you're engaging in these exercises.
It does seem though like what you were saying is that because you would assess to kind of say where is this pain, and then the treatment varies. Like you're not just like we just exercise. It sounded like this might be more of a stretching kind of exercise for this, and this might be. That's correct, right?
Yes. And anytime, if you experience pain, do communicate with your team, like if it's an exercise professional, whoever you're working with, engaging with. So they'll give you some modification. And at times, even that will be very beneficial to help you cope with the pain. So the key will also be important to regularly communicate with your provider and with your team about your pain presentation, what's working, what's not working, and simultaneously tracking it. So it needs like a dynamic approach and dynamic care to resolve it and better address it.
I just lost my train of thought. One thing that somebody else had kind of mentioned when you were talking about one of the poll questions about the pain, stop limiting activities. What about though when the fatigue is also limiting? So it's like kind of people don't want, yes, there's pain, but then there's also fatigue. How do you deal with that?
So one of the key thing is doing like a graded exposure. So assessing like, what's your limit? Like is for any exercise, for instance, like 10 minutes is where, is a good time. Following like the 10 minutes, you start feeling more of a discomfort, more of an irritation. So that's like assessing the baseline. If it's 10 minutes, then gradually ramping it up. So fatigue and pain is it's balanced and it's not overdoing it or underdoing it, and keeping the window like maintaining your exercise routine within the window, and making sure you do gradually increase it. Like it won't do good if you keep the same intensity for a long time. So thinking both ways will help to keep constant the dosage of exercise constant, and then increase it. And if you do feel fatigue, and if your fatigue is more dependent on the time of the day, then the other thing which you can look is early morning better? Does that help you better? Is that a better time for you to engage in exercise, or different time of the week? So exploring that will also help you manage the fatigue and keep up with the exercise.
Okay. Someone asked, one of the non-motor symptoms of PD is the selective sensitivity of the body. For example, temperature sensitivity is one thing. Even when your feet are freezing, you don't realize it, and the upper part may feel warmer. Do you find that this same pattern, the pain, follows the same pattern in Parkinson's?
Yes, to some extent. So it's more of an autonomic dysfunction at times, which is more experienced as a non-motor signs in Parkinson's disease. So if you experience any of the changes in the sensitivity, temperature sensitivity, then it's important to notice and make sure you're regularly checking, assessing the region, so you're not you're protecting the joint at the same time. And one of the simple ways to address it is the sensory training. So just using I'll just simply describe it, but it depends on the overall condition and the response. So gradually introducing different sensations and stroking different sensory stimulation across the foot, legs, and seeing how's the response. Is that changing the sensitivity? While you do this, also connect with your team and communicate about this finding, so they'll also be able to brainstorm some treatment ideas with you.
Do you also ever go over ways to improve posture or fix posture while you're doing exercises?
Yes. Posture is really important, and one of the effective ways to address the musculoskeletal and other types of pain is making sure you're able to keep up with good posture. You're able to, if you have a good posture, that tells a lot about your strength, your flexibility. So everything goes hand in hand. So posture is important to be addressed. Yeah.
You kind of laid out like a 4-week class. What happens when people are done? Obviously, they do need to continue doing this. It's not gonna, they're just gonna be right back to where they were if they do it for the 4 weeks, go, yeah, I feel great, and then don't. So how does, do you give them homework? What is kind of the continuing education, if you will?
So the continuing education is more like a support group meetup. So we have the people who've been participated in these cohorts. They regularly meet up, and it's a guided session. So we talk about the new evidences coming. What are the new strategies which can be looked into and implemented, and that's delivered. And also learning from each other. Like everyone has some new ideas on how they are coping with their pain. So those exchange of ideas and sharing materials, updated research is a way to connect and learn from each other on a monthly basis, followed by the 4 weeks program.
Is it okay, because it is virtual, if they were to tape it so that this way they could go over it again, or no? Is that frowned upon?
Yes, so all the sessions are recorded, and then there are a lot of self-learning tools which are also given to them, so they can like a workbook and regular pain diary assessment. So this they can refer back and keep a track of it through the forms, and also learn about the skill sets which they actively repeat and practice on a daily basis. So that's the foundation of it.
One other question, again, I'm like losing my train of thought. You talked about the pain diary. What would you have that look like? Because I feel like sometimes people don't really want to journal. And so I often say, like, for example, you do want to keep track of like your Parkinson's symptoms. But at the same time, I'm like, no one's going to write, what would you be looking for? Almost like a time and like certain like pain here. What would the pain diary look like?
So the pain diary primarily, like, just putting down the onset of disease that can be, done like at the start of it, but tracking like what are the like the key thing is the duration of the pain, like how long do you experience it? What are the relieving factors? What are the aggravating factors? And does it change over the course of the day? Like, is it different during the on phase or in the off phase? Those are the key things to write it. So even, on your notepad or even on the phone, if you can quickly like put down the summary of the day, like even, just for the day, end of the day, if you want to put down few highlights, that will be a good information to look into, and that will help the providers to further diagnose it. Because when you go to the doctor's appointment, you have very short time and you have to say it all, and it's hard to like concise all the information. So that will be a good objective information and subjective information too.
No, but I like that, like also to think about what maybe aggravated it and such, because sometimes we kind of know that it was like I wasn't sitting properly, or I sat for an extended period of time, and that was something you'd probably just want to think more consciously about, as opposed to just I have pain and I don't know why. So
I agree. And then, there are days when you have it for 3-4 days and it gets resolved like end of the week. And then, that's good to go, right? Like probably just work on strengthening, but nothing to worry about for a long time. But there are pain which typically fluctuates with the motor symptoms. That's when you want to really let your movement doctor know about it, so they can look into the medication piece too.
So much for your time. This was so enlightening. This was wonderful. I learned so much. As always,
thanks for having me.
We do encourage, again, everybody to save your chat. There are the 3 little dots to save your chat, because there's a lot of information about her blog as well as how to reach out to her. So we really encourage you to do that. Thank you so much. And of course, our wave of gratitude here at PMD Alliance to say thank you. We really appreciate your time today. Thank you.
Thank you so much. It was great to talk to you all.